Good afternoon, everyone. I'm Dr. Yin Xiuxu from Taiwan. First of all, I have to thank Professor and Uri, and thanks him to invite me to this wonderful place, wonderful meeting, and I'm truly grateful for that. And my topic today is modified DISE.
Right.
Yes. And first of all, I think many people don't know where Taiwan is, and let me present some numbers for you. This is Taiwan, and this is Taiwan Strait, and there are 48% ships go through Taiwan Strait every day. So it's very busy, and it's very important for global economy. And there are 92% advanced processed chips made in Taiwan. So they are maybe using our chips in your computers and cell phones. And because China insists that Taiwan is part of China. So after Ukraine war, many people think that Taiwan is the most dangerous place in the world because China may invade Taiwan. But it is what it is. We need to do what we should do. For me, I'm the Taiwan Sleep Society Sleep Surgery Deputy Chairman now, and Taiwan Otolaryngology Society Sleep Medicine Training Committee Deputy Convener. And I received 2020 and 2022 Doctor Paper Award of Shin Kong Hospital. This is my award. And I'm otolaryngologist and brain science PhD. Program in Yangtze University. I'm also an obesity specialist of Taiwan. I visit New York, visit Alfred Jacobus and Professor Maria and Professor Vicini in Foley, and they start my career. I'm very thankful for them. And these are my recent publications. Without those mentors and friends of mine, I cannot achieve that. And back to our topic, this is a DISE, and we put patients in sleep, and we can see what's the obstruction site of them, maybe from tonsils, and maybe from the tongue base, and maybe their obstruction in epiglottis anterior-posteriorly or laterally in the epiglottis. So DISE have many, DISE can help me to see where the obstruction site is. However, there are some limitations. First is a short duration. They cannot present the whole night sleep of the patients, and there is no REM stage in the DISE, and it's an intraluminal view. We don't know what happened outside. And however, the DISE has also advantages. First, patients is asleep. You can do whatever you want to do. You can do the jaw thrust, you can do chin lift, you can do head rotation, and you can do the nasal way to see what happened after that. And so this is a study in 2017. My mentor, Alfred Jacobus, helped me to publish that. We found that after paratopharyngoplasty, we found that everybody improved a lot. However, preoperatively, the tongue-based obstruction in the DISE did not correlate with the posterior operative outcome. On the other hand, circumferential pharyngeal collapse correlate with the outcome, and people with preoperative circumferential pharyngeal collapse may have worse outcome after the surgery. So, in this study, we found that tongue-based obstruction in DISE did not affect the post-PPP outcome. However, this may raise the question that did the VLAN treatment make tongue-based obstruction disappear, because everybody with a preoperative tongue-based obstruction is still doing well after the surgery. However, in that era, with Alfred, we did DISE with manual injection of propofol. So the manual injection may cause the manual tongue-based obstruction. So DISE with manual injection of propofol may need to be modified. This is my topic, main topic today. We will discuss later and how to modify the DISE. Thanks for the Professor Vicini. He told me how to do the TCI-DISE. TCI-DISE means we are using target control infusion and use bispectral index sleep test monitor to help maintain the appropriate sleep test during the DISE. And in this publication, he found that conventional manual injection of DISE may cause sudden pharyngeal collapse without snoring. So this finding may because of the drug. So and by using TCI-DISE, the accuracy, the apnea, the snoring and the accuracy become higher, and stability higher, and safety higher. So this TCI-DISE is a better way to do the DISE. Then there's a question after I learned this technique. I think will TCI-DISE diagnose tongue-based obstruction more consistent and accurate and help us to our treatment plan? So I published, many years after that, I published this paper in the Nature and Science of Sleep. This is a high prefecture journal, which high imperfect is more than 5. But as you know, this paper, this journal decreased its imperfect recently. Hopefully, it's not because of me. Okay, we collect 34 patients, we do partial pharyngeoplasty preoperatively, and postoperatively we do TCI-DISE and sleep exam, and to see that if the tongue-based obstruction preoperatively will still present in the postoperatively. So we found that before the surgery and after the surgery, the tongue-based obstruction did not change. They still present after the surgery. And the tongue-based obstruction preoperatively and postoperatively in TCI-DISE affect outcome. The people with tongue-based obstruction have worse outcome than those who did not. So TCI-DISE, besides the CCC, is sacropharyngeal pharyngeal collapse. The tongue-based obstruction in the preoperative and postoperative TCI-DISE correlate with the pre-op and post-op HI severity. So TCI-DISE can help us to diagnose tongue-based obstruction consistently, because before and after they are the same, and accurately because it can affect the surgical outcome. So we can use TCI-DISE to design our treatment plan. Yesterday, our panelists were discussing the DISE, and most of us are using TCI-DISE. Personally, I think it's because of this paper, nobody can stop me from thinking of that. And if we know the TCI-DISE is helpful, we can use a lot of device to see if there is a treatment effect. One of them is intraoral negative airway pressure. This device is designed by one of the great innovators in Taiwan, Dr. Tianzhen Liu. And this device works like this. It sucks the saliva from the between the palate and the tongue, and help patients to keep their mouth in the negative airway pressure, and so it keeps the tongue in the stable position, and the tongue it help them to close the mouth. So this is our protocol to do that. To do the first INAP and head rotation, then the supine, then head rotation. So why we use head rotation instead of trunk rotation? This is idea come from this paper from Professor Nico de Vries. They found that in 60 patients, the collapse pattern of head rotation in supine position did not significantly different with trunk position. So only minor alveolar obstruction are affected. So it is a reliable maneuver to help us to see if the position affect the patients. So this is our study result. It also published in the Nature and Science of Sleep. In the 92 patients, we found that INF therapy have effective in 40 patients in VLAN, and 13 patients in oropharyngeal, and 39% in tongue-based. And when we combine this therapy with hair rotation, 51% VLAN effect, and tongue-based 47, and epiglottis 21. So to summarize that, in TCI-DISE we found that INF therapy is effective to VLAN in supine position, oropharynx, tongue-based, and when we add the head rotation, it may be effective to VLAN, tongue-based, and epiglottis. And some of the, not everyone are responsive to the INF, and some of them have complete relief after the INF with the hair rotation. So, those people have less BMI, and they are older, maybe more than 50 years old. So those patients may be more susceptible to use the INF. Then recently we published a paper in the otolaryngology head and neck surgery, which is doing the modified DISE. And how do we modify that? We tried the oral appliance. This is a simple oral appliance, and we can use this one patient, and we wash it again, and we use it to another patient. Very, very simple, very easy, and very cheap. And this is our protocol. We use the supine position, hair rotation, then using oral appliance supine position, and oral appliance hair rotation. What do we find? We collect 83 patients, and in 23 patients of them, they have persistent concentric buropharyngeal collapse, even in the oral appliance with head rotation. In those patients have significant higher, this is a head rotation with the oral appliance, and this is not still have a CCC. And those patients' total AHI are significantly higher than the others. Also, those patients' supine AHI are significantly higher than the others. Again, those patients' BMI are significantly higher than the others. However, for non-supine AHI, there is no difference. This is for VLAN. How about tongue-based? In the total, if they have a persistent tongue-based collapse in hair rotation with oral appliance, those patients have significant higher total AHI than the others. And they also have higher supine AHI than the others, and they have higher non-supine AHI than the others. However, those who have persistent tongue-based obstruction, even in hair rotation and oral appliance, have no BMI difference than the others. That's give us a hint that tongue-based collapse maybe in the hair rotation and oral appliance, maybe it is more like from the anatomic reason. So to summarize, in our modified DISE, we found that persistent velar collapse in hair rotation and oral appliance related to higher BMI. So for those patients, maybe we need to add weight control in our treatment plan. And for persistent tongue-based collapse in hair rotation and oral appliance, they are not related to higher BMI. So this might be the candidate for surgery because we need to remove the maybe enlarge lingual tonsils. And because all my DISE patients refuse to use CPAP. So for patients with CPAP non-compliance, we may use the modified DISE to do the OSA phenotyping. For example, for patients with less BMI and older, we may use INAP. And for patients with hair rotation, responsive to hair rotation, we may suggest to do the positional therapy. And for those who have a persistent obstruction in oral appliance and hair rotation, if it happened to VLAN, we may ask him to do the weight control. And maybe if it from tongue-based, we may ask him to do the surgery. I think we might be really willing to do the surgery to him. So, for example, the patient data, it is a case of mine. and he's a 41-year-old. He's a high HI, and in the modified DISE, we found that this is a supine position, which has midopharyngeal collapse and I think hypopharyngeal collapse. And if we put in the head rotation, we found that there is still midopharyngeal collapse and the tongue-based collapse. And even these findings even presented with head rotation with oral pines. Okay, it's very tongue-based collapse. So what did we do? We do the operation for him. We do the suspension pharyngoplasty. We do the nose surgery. We do the transoral robotic surgery. This is the suspension pharyngoplasty we did. We expand the viropharynx by suspension, and we do the transoral robotic surgery to remove some of the tongue base. And after the 3 months, we found that although these patients have improvement in AHI, but still very high. It's still severe sleep apnea. Then we need to do the modified DISE again to see what happened. We found that even we remove the tongue base and relieve the tongue base obstruction, the patients still have anterior posterior palatal collapse, and it's also present in the head rotation. However, when we use the oral pines, these obstructions disappear. So we asked him to use the oral pines. Then we found that although pre-oral pines, the HI is very severe. After the oral pines, the HI almost totally disappear with good situation. So this case helped us to certify that modified DISE may work. So this is my talk. Thank you, Toda, Haba, and merci beaucoup. And I had a wonderful time in Israel, and I hope we can see each other again very soon. Thank you very much.